to hand off, or so they're going to have slides. So
Yeah.
good morning, everybody. It's great to see you all here. I know a few of you might have been out last night celebrating AFS and our wonderful colleagueship. So could ask everybody to take your seats. We're going to get started with the first session of the morning, Beyond AFS. So many of you may not know this, but the presence of AFS has triggered an excitement about multidisciplinary care of foregut disease around the world. And so we're going to hear a little bit about that coming from the east, the west, and the south this morning. Dr. Lister is going to lead us in that discussion in just a second, but I just want to remind everybody that we have an exciting program today. This morning we'll have the Beyond AFS session, followed by the Eradicated Barretts, What Comes Next session, and then we're going to see the best of the submitted science from our top presenters from our abstract competition. They'll be giving oral presentations and have an intense grilling from our judges as part of the Q&A session right here in the main ballroom before we go off to our Lunch and Learn. So if you have not registered for Lunch and Learn, please make sure you click on or select the QR code that are flashing outside, register for one of them. I think we have 3 great sessions today over lunch, and then we'll come back here for the final session this afternoon. So without any further ado, Dr. Lister, please take it away, Beyond AFS.
Thanks, Mike. Welcome, everyone. For those of you that were present at my first talk, you know I'm very passionate about esophageal cancer. And on that note, I want to bring up Shri Kamanduri to give us a little update about ECAN. Yeah.
People will be looking at my shoes.
Are we good? Oh, there we go. All right, good. Too much. Everybody okay? I don't want to destroy your ears first. And so thank you for this invitation. And clearly, I need to work on my casual wear, but I'm going to fix that later. I'll get this tie out of here against the rules of the course. But welcome to everyone this morning. And just in the next few minutes, I'm going to speak to an exciting initiative that we're putting forth through the Esophageal Cancer Action Network. For those of you who are not familiar, this is the largest patient advocacy group for patients with esophageal cancer and at risk for esophageal cancer as well. And one of the things we've thought about over the years, and all of you, especially in the healthcare, who are direct healthcare providers, understand the scenario when you're given a diagnosis and you have friends and family who call you every day. Some of you will get a call today saying, hey, so-and-so was told they have X, and how do they get in quickly? What do they do? And at least in the American healthcare system, you got to know somebody, right? And to get something done tomorrow nowadays. So we wanted to get through that, and how do we give an average patient that VIP type experience, right, where they're actually able to find the best providers and actually get in to see them in a rapid fashion, through advocacy. And this is part of what we're trying to create. So this idea of a Center of Excellence program for esophageal cancer is really based on very obvious facts of rising incidence of esophageal adenocarcinoma, despite the 20 years of endoscopic eradication therapy that we're going to talk about in the next few sessions. There is often a delay in diagnosis and management, and this happens even in our field in GI when we're seeing patients 7 months later, 6 months later for Barrett's-related neoplasia. But imagine the patients with esophageal cancer, and if you think in your mind, how rapidly do they actually get their care, and how quickly do they understand who are the best people to see? So ECAN really is aiming to help patients at high risk find premier healthcare facilities that provide quality multidisciplinary care for patients at risk or who may have been diagnosed with esophageal cancer. So really to ensure quality and equitable care for all patients with a focus on providing the best possible outcomes. And I think that equitable care is really critical to the story. Sorry about the busy slide here. So this is a designation. So those of you who might be familiar with the National Pancreas Foundation and PanCan, so the NPF has an analogous scenario through patient advocacy for a designation of a center of excellence. And this is not an academic designation. This isn't based on your academic rigor of publications and research. This is just based on the ability to provide that high-level multidisciplinary care. So kind of some of the same things I said, there is this, delay that we're trying to overcome. And basically this COE designation that we're proposing or going to put forth will really be a beacon for patients to identify centers where they can receive that high-level, comprehensive, and quality care. I think centers designated as a center of excellence will provide that highest level of clinical care, and I think that's the key piece. There will be emphasis on quality metrics and outcomes for sure. So essentially we'll go through a rigorous application process, and we spent a good amount of time mimicking and talking to the National Pancreas Foundation to understand how they do it. We've worked sort of trying to be as thorough as possible in identifying a lot of the key stakeholders who are in the room, and not only just not only gastroenterologists, surgeons. Initial designation will be clear of oncology, simply because we think it's probably too large at this point to be that inclusive. So this is going to be more of, the sort of barretts through detection, through diagnosis. So the gastroenterology surgical collaborative effort, and that's kind of why it's being presented here. So finally, as a patient advocacy organization, ECAN would designate centers of excellence to provide patients with valuable information and make their important decisions about their health care. It will not be focused on, as I said, a research distinction for any institution. What does that look like? It's a laundry list of people that we all work with in many of our scenarios, but sometimes it's lost in certain centers where patients end up, and it is critical depending on the scenario, the time of diagnosis, a lot of things we're talking about here, because some of this is preventative, some of this is diagnostic, and some of this is therapeutic. But there's a lot that goes into the management, and this really does emphasize, I think, the entirety of what the sort of esophageal cancer aspect of what we're talking about at AFS, this continuum of reflux to cancer. And it's not a one-point story where you're just a Barrett's doctor or a reflux physician or a thoracic surgeon or a GI surgeon. You really have to be involved. And I think we see that with the type of faculty here and the physicians we have here, that we understand that this starts at the beginning of reflux and ends all the way through cancer, and we have to manage patients with that mentality. Some of the basic requirements are, a lot of these experts obviously have to be board certified. There will be some emphasis on expertise, number of providers, like we just talked about, volumes to a degree that makes sense. And as you would imagine, this is perhaps not as important on just diagnostic endoscopy, for example, but very critical for esophagectomy. So there has to be some thought process put into that as we move forward. Part of this gives us an opportunity, if we do this well, to look at standardization of things like best practices, and can we actually make this not just a designation, but something that becomes proactive and collaborative moving forward. Lastly, I think the sort of emphasis on novel innovation is critical. As you walk through the exhibit hall and you see all the talks here, we're at a really pivotal point of having a tremendous amount of innovation in the field of esophageal cancer, Barrett's, reflux. And I think part of our goal is to ensure that we have adequate adoption and implementation of innovation when appropriate to do so. So lastly, some of the things that we would track, things that involve endoscopy, early prevention, detection, high quality exam. Some of these are just ideas. The whole process is currently in a status where we've gotten together with a group of core gastroenterologists and surgeons, and we walk through the idea and some of the caveats related to what might be involved with the designation. As you can imagine, there was a lot of feedback and input, and many of you were providing that in the room. And that's being collated now, and ultimately we will, together as a group, vote on, almost in a pseudo-modified Delphi process, what are the critical aspects of that designation, and then this will go out. And again, this is just an idea of some of the quality and reporting, and this will be TBD. This is not everything and all-encompassing at this point. So as I said, we will continue to collaborate with the American Foregut Society. I think they have a strong vision of looking at an academic center of excellence in esophageal disease. I think the two concepts can commingle and actually energize each other. I think it's critical at this moment, given all the innovation we do have, all the success we've had, and all the amazing things that are being done, that we really focus on the patient and provide an avenue for advocacy for them to find the best possible outcome. Goal is to launch this early in 2025, so we'll have more updates for you as things move along. Thank you.
Thanks, Sri. So when we started the AFS, we started out kind of as a small club, and none of us realized the momentum that would generate from when we started this organization 6 years ago. We started out just the U.S. Group, and we quickly found out that there was a momentum around the world. And the first people that reached out to us were our colleagues across the pond in Europe, and our sister organization, the European Foregut Society, was born. And I'm going to bring up its president, Nick Boyle, to give us a little update about where we're at with the EFS.
Thank you, Dan. Thank you. Good to see you. So it's first thing in the morning, so I think we should be a little bit light-hearted. Actually, could I have my slides, please? That's I'm not Japanese. No. Have you got the right slides there? Have we? I think I need my slides. 1 minute.
Hey, Nick, I'll tell you what, let's do this.
I don't think either of those would be very amusing.
While they're just for the sake of time, while they're getting your slides ready,
why don't we get... Well,
Alex doesn't have any slides,
Alex,
so we'll bring Alex up. Alex Neaponce from Buenos Aires came up to me at the meeting last year or 2 years ago, and introduced himself, and a great friendship has arose from that, and he has brought Latin America into the AFS family, as North and South America are one big America. So they joined, they're not creating their own society, they're joining us.
Correct.
So give us an update.
Thank you, Dan. Well, I didn't want to get my slides in trouble, so I brought no slides. Basically, as Dan said, we are not launching a Latin American Foregut Society because several countries have very different politics and treasurers and politics. So, and we are America. So the best thing to do was to be one America and just foster membership to the AFS mothership. And that's been happening. And one of the things I want to highlight is that we have interacted with other American societies before, North American societies before, like DW and surgical societies, but we have never seen the way that AFS has been actively embracing bringing people from the South by really paying attention to the needs and to the pitfalls that were stopping people from coming here or involving themselves in the society. One of them, for example, was why would I submit an abstract, to US if I have 10 patients and they do 200? So it's impossible to compete. And Dan in 1 minute said, well, that's easy to solve. We will have an international abstract category. And now, for those of you who are not in America, there is an international abstract category that you can apply, and one of those gets a podium. So that is a big step, and that's encouraged people to submit work. Travel awards, things, to make life easier for people to come. We've been doing online meetings with people from all around Latin America and Asia. Now, Toshi will tell you about the Japanese Foregut Society, but also Ian is, I know if Ian just went back, or is he around in the room? Oh, there's Ian, from Hong Kong. They wake up at 5 a.m. in the morning to be in those meetings. It's amazing. And we are really having an international collaboration that will get Foregut probably expanded. But I think the concept of bridging all the continents and bridging all the people is what we need to do to make Foregut happen on all the bases. And when you go to Latin America, especially, and probably in some Asian countries as well, but it happens also in Europe and America. We are academic centers. Most of us, we work in academic centers, but we need to go to spread the word at the community level. I think that is the strongest mission of this type of societies, because if we want to achieve what Sri just showed us, we need to go to that level. It won't happen from the top to the bottom. It will happen if we all educate the community and we bring it up together. So thanks again, AFS, for embracing the South, and we look forward to what's happening in the next World Foregut Summits.
All right. Thank you.
Thank you.
All right, now once again, we'll bring up Nick Boyle from the EFS, and hopefully we'll have the right set of slides this time.
So, on the second day, God created man. And amongst those men, some were more equal than others. Some were perceived as being gods for what they did and what they knew. Who knows who that is? It's Hippocrates, and this is Galen. So they were viewed as gods amongst mortals for their wisdom in medicine. And what about that? Who's that? I'm in America. It's William Mayo. And who's that?
Barrett.
No, it's Nissen. And who's that? Tom de Meester.
Tom.
And for the English, you may know that that's a great surgeon arriving in his Rolls Royce at the hospital where he's welcomed by his team, Sir Lancelot Spratt, as he was known. So those were the days when doctors ruled the world, but things have changed. You may have heard of this concept, popularized in the 1980s by an architect, I think he was, called Buckminster Fuller, who came up with this idea that for most of humankind, the amount of knowledge, the sum of the total of human knowledge, doubled about every century. And then in the Industrial Revolution, it gathered pace. After the Second World War, every 25 years, the amount of human knowledge doubled. And now, it's apparently doubling every year or so. And with AI, who knows what's going to happen. So what we can do as doctors has changed. And that's the back of Sebastian Schottmann's head in an operating theatre in Vienna. And you just look at all the stuff in there, all the technology being applied to that surgery. And of course, it's not just surgeons who do things to people now. Gastroenterologists now are able to do all sorts of stuff, and the ability of us all to treat the patients that we all see every day has grown as technology and our knowledge has changed so much. And that must necessitate us working together better. But you know, we can do great, we can do good, and we've heard some amazing talks about all the good things that we can do. But remember, we can also do harm. So this is a big study looking at American insurance data, comparing volumes in fundoplication. Centers doing less than 10 operations, intermediate 10 to 25, and over 25. If you have an operation in one of those low volume centers, you'll be twice as likely to get a complication. And all of those different kind of complications are related to volume. It's not surprising, we know that, don't we? This was Sherasmarka's study from the United Kingdom. He looked at both hospital but also real data from the community of patients who'd been treated with anti-reflux surgery, fundoplication, over 12 years or so, or 14 years I think it was. And do you know what? 10% of those patients had another operation because it had failed, and about 50% were back on PPIs. So overall, we'd failed 60% of those patients on the face of it, which is not great, is it? And do you know, this was related to volume as well. Those are Kaplan-Meier's for the likelihood of reintervention over time. And the worst outcomes are associated with what he defined as low volume, and the average per year, 5 operations a year. Can you believe that? 5 operations a year. It's not surprising they're not doing very well. I don't believe Ronaldo would do very well if he only played football 5 times a year. And we know that that still goes on. This was a survey undertaken in the UK, published just last year amongst all upper GI surgeons. About half responded, so you can imagine the ones that didn't probably were less good than the ones who did. But nonetheless, the average number of operations being done in the National Health Service is 1 a month, and privately is 1 every other month. And you know what? Less than half bothered to ask what the HRQLs were before they did the surgery, and less than 20% afterwards. Surgeons in the UK mostly haven't got a clue whether or not they're helping their patients' symptoms. And I rather guess it's exactly the same in the US and exactly the same across the rest of the world. And, you know, most don't have an MDT, and when they do have an MDT, only a third include a physiologist, which is extraordinary, really. I can remember doing an operation, and a very well-known gastroenterologist popped in to have a look at what I was doing. And I was doing a hiatal dissection. And it was quite clear from his reaction and the conversation that we've had that despite the fact he does poems, despite the fact that he spends his time looking at the esophagogastric junction, he really had never appreciated the anatomy in terms of the relationship of the esophagus to the cruor, et cetera, et cetera. So this is what we're all trying to do. We're all trying to improve outcomes for patients by collaborating, by spreading knowledge between all of us. I was having breakfast this morning with some people, and they were saying in their country, gastroenterologists and surgeons don't talk to each other. They hate each other. I'm sure that's an overstatement, but we all know that there's a little bit of element of truth in that. And that's why when we come to a meeting like this and we see everybody working together for the same end, it's fabulous. Now, I don't quite know what's happened here. Here we go. If you look at the mission statements of the AFS and the EFS, you'll see that they align. And that's because in life, it's usually best to copy good ideas from other people. And actually, that's what we've been doing at the EFS over the last 3 or 4 years. We're bringing together people from all over Europe. We are doing the same in trying to bring women in, and we'll be having at our forthcoming meeting exactly the same way that yesterday there was a women's meeting. We'll be doing exactly the same, and that's led by Dagmar Coleman from Vienna. We've had 3 meetings so far. The first held in the midst of COVID in Vienna, hosted by Sebastian Schottmann. Really challenging. We just got in between 2 lockdowns, and we've held 2 meetings since, the last in Milan. And we are growing in the same way as trying to emulate the success we're seeing in the US. It's probably a bit late for those of you who haven't already decided, but the next meeting at the beginning of November will be in London. And if that's too late for you, we'll have another meeting. The next meeting after that will be in Athens the following year. So I really encourage you to try to come along to that if you can. We've been joined in the last, to all of our meetings, from our friends from America, which is fantastic. I just thought I'd finish with this this Bravo study. It was reported, I saw the patient as a second opinion, and the surgeon had said, I don't quite know what to make of it. And ultimately, they hadn't actually looked at the tracing, which quite clearly shows that the Bravo capsule, in this case, the pH capsule, had fallen out. But the entire study reported a positive study because, of course, for quite a long time, the capsule was sitting in the stomach. And it's by bringing us together to understand what we all do collaboratively that we'll end up not making mistakes like that. So it's going to be great to work with our friends across the rest of the world, and I just personally feel it's a fantastic thing to be part of such a great community. So, thank you.
Next, our colleague from New Jersey, Toshi Hoppo, is going to talk to us about the Japanese Foregut Society.
Now it's my turn. Good morning. I'm so honored to be here as the president of Japan Foregut Society to let you know we had a very successful first JFS meeting in Tokyo last year, thanks to everybody's the support. So now I do not have my slides. Well, so I'm going to keep talking, but oh, yeah. Okay, so I want to briefly talk about the GERD situation in Japan. So there has been a rapid increase in the incidence of GERD since 1990. So approximately 40% of Japanese people seems to have GERD symptoms daily. So this number is very similar to the situation in the United States. So we do have a fantastic specialty service. However, there has been no tight collaboration in between. So since the introduction of PCAF, the many GI thinks the PCAF may be able to cure the most of GERD. Also, the Japanese GI is very particular about the endoscopy. So they tend to think that everything can be done endoscopically, including diagnosis and the treatment. On the other hand, the Japanese surgeons are very meticulous about the cancer resection with the beautiful lymph node dissection. However, they have avoided doing the surgery to treat the benign disease process because of fears to the lifelong post-operative complications. So based on the database, the 3,500 esophagectomy was performed in 2021, as opposed to only 434 fundoplications. While the number of gastrectomy has significantly decreased because of the HP eradication, more and more sleeve gastrectomy has been performed to treat type 2 diabetes, creating more post-sleeve GERD. So the ENT doesn't know the disease process of GERD or the LPR. So as you expect, we do have common issues in the foregut practice in Japan. But I think the biggest issue is the limitation to the access to esophageal testing because of our unique health insurance system provided by government. So the reimbursement of manometry is only $50. So who wants to introduce esophageal testing in the clinical practice? So we needed to have our foregut society to improve this situation. So here's what I did to prepare for JFS. First, I needed to find the Japanese foregut bodies in Japan. And I published the GERD textbook in Japanese with them. And eventually, we were able to include the top GI guys who has created the guideline for the GERD as a board member. We try to invite the younger generation, paramedics and the people from industry to collaborate. Eventually, we were able to get the funding from the 14 industries. Then the most important things to do for the successful first JFS meeting was to take care of this guy. And then eventually we had the 114 attendees. We had the educational seminar to learn the basic of esophageal testing so that everybody understands better. As a highlight of JFS, we had the international joint session with AFS and EFS. John gave us a fantastic talk. Sebastian and Igor gave us an online lecture. Thank you very much. And we had a great multidisciplinary discussion, even after the meeting, as you expect. So I don't even recall how many glasses of Japanese beers we had for 2 days. So now we are ready to have the second JFS meeting in Tokyo next Saturday in a week. So this time, we are very excited to have our great Dr. Bell from US online, Ian from Hong Kong in person, and Eve from Switzerland online. So we really look forward to it. So now the AFS was established in 2020, EFS was in 2021, and the JFS was in 2023. What comes next is, yes, Asian Focus Society. So Ian is the guy who has been working really hard to put everything together to make it real. So at the time of Hong Kong the master class on this coming December, a pair of GI and a surgeon from Hong Kong, Japan, Korea, mainland China, and Singapore will meet to move on. So we are planning to do the first Asian Focus Society meeting in 2025. So as Alex mentioned, the Latin American Focus Society is going to be a family of AFS. I believe the ultimate goal is to develop a global Focus Society. So left side is a group of Japanese Focus buddies with John. So I have to mention here the AFS kindly offered all of Japanese Focus Society members to be a one-year complimentary AFS associate members. So everybody can access to all the benefits of AFS. I really appreciate your support. And the right side is the founding members of JFS. Tomoko is our Kate. So we would love to keep working together with all of you. So we are going to be internationally better together. Thank you very much.
Thanks, Toshi.
Thank you.
And to kind of culminate that, in 2026, our meeting in Washington, D.C. is going to be an international meeting where we bring all of these groups together. So something to look forward to. I think since we're running behind a little bit, we'll go ahead and proceed to the next session. I'll bring up Mimi Canto and Christy Dunst. Gentlemen, thank you very much.
All right, no worries. We have an hour break. We'll keep ourselves on time. We're going to do the session, and then Dr. Canto, my color-coordinated partner, is going to run into a case presentation discussion after that.
Are you on? Just wanted to make a comment. Obviously, we've made great strides. I know that according to Felice, 40% of us in this meeting are GIs. So, and this is a Barrett session, so we're really excited about it. This is about post-eradication Barretts. So we know that years ago, we used to send people for esophagectomy. Now that's almost like really a drastic thing, and we now are in an era where endoscopic eradication really, really works. But what's clearly the problem now is what to do with our patients. Are they discharged? How do we follow them? How do we detect recurrences? So I'd like to bring up the first speaker, Sachimwani, who is a local, to tell us about this problem. You want to walk around or be at the podium? Yeah.
Sounds good. All right. Welcome to Colorado. I want to thank you all for being here and the organizers for this kind invitation. So in these next 10 minutes, this is what I hope to cover. I'm going to try and answer this basic question of how commonly are you encountering Barrett's esophagus or Barrett's-related neoplasia after you've achieved the endpoint of complete eradication of intestinal metaplasia. When are you most likely to identify patients with a recurrence? What are the predictors of recurrence? And what are the principles that you should be using in your clinical practice, not only to identify patients with recurrence, but also how should you manage these patients when you do see someone with a recurrent Barrett's-related neoplasia? What are the sampling techniques? How often should you be bringing back? These are all some of the things that I hope to cover in these next 10 minutes. And then also answer this question, in 2024, are we ready to provide a personalized approach to our patients who've achieved the endpoint, crossed the finish line, and achieved complete eradication of intestinal metaplasia? I'll be using established quality indicators and recently published guidelines, but I'll also take a couple of minutes to just shed some light on some of the knowledge gaps as it relates to management of patients undergoing endoscopic eradication therapy and tell you about some of the studies that we are doing to address some of these knowledge gaps. And these are the guidelines that you should all be familiar with. The one that I will be focusing on is the set of guidelines that we published through AGA about 3 months ago, specifically focusing on endoscopic eradication therapy. So to set the stage for the session on post-endoscopic eradication therapy related neoplasia, I think we all recognize that our goals of performing endoscopic eradication therapy is to first achieve complete eradication of intestinal metaplasia. Once you achieve that endpoint, all of these patients should be enrolled in surveillance programs so that we can identify Barrett's and Barrett's-related neoplasia recurrence. But of course, remember, our ultimate goal is reduction of esophageal cancer mortality. So the first question is, how often are you going to encounter Barrett's and Barrett's-related neoplasia after you've achieved that primary endpoint? And these are the data that have been published. The top 2 rows really highlight data from systematic reviews and meta-analyses, and the bottom 4 really focus on contemporary studies that give you some idea of these recurrence rates. The endpoints that you should care about are recurrence of Barrett's, recurrence of Barrett's-related neoplasia, and finally, recurrent Barrett's high-grade dysplasia and cancer. And if you look at the contemporary studies, the recurrence of Barrett's ranges from about 5 to 10 per 100 patient years. The incidence of any neoplasia ranges from about 1 to 3, and for high-grade dysplasia or cancer, which is what I think you should really be focusing on, it ranges from 0.7 to 1.6 per 100 patient years. The point that I'm trying to make with this slide is that recurrence rates of Barrett's-related neoplasia is fairly low, especially if these patients are managed at expert centers or tertiary care centers. It's also reassuring to note that the vast majority of recurrences that you're going to see in your practice will have the same or lower grade of histology compared to the histology that you started off with for endoscopic eradication therapy. When are you most likely to encounter a recurrent Barrett's-related neoplastic lesion? It typically is seen at about 18 months. That's when it really peaks after you've achieved your endpoint of complete eradication of intestinal metaplasia. Again, questioning the rationale for all these frequent endoscopies that we do after we've achieved complete eradication. What are some of the predictors? I will tell you we have really limited knowledge in terms of predictors that are associated with Barrett's-related neoplasia recurrences. These are some of the data that have been proven from other observational studies as well. Your baseline histology grade is probably one of the most important predictors. With patients with high-grade dysplasia or cancer are most likely to have a recurrent lesion. Patients who require a higher number of endoscopies to achieve complete eradication of intestinal metaplasia. And finally, patients with uncontrolled reflux, large hiatal hernias are also patients who are likely to have recurrence of Barrett's-related neoplasia. So what are some of the things that we can all do in our clinical practice so that we can identify these recurrent lesions? I will tell you the principles are no different from the principles that we should be using when we perform a screening or a surveillance exam. A high quality endoscopy is still absolutely critical. Here's a patient that was referred to our practice who had undergone radiofrequency ablation several years ago for a baseline diagnosis of high-grade dysplasia, and then referred to us for this lesion. And you can appreciate this lesion seen in the 9 o'clock position, and you can really use high-definition white light endoscopy and virtual chromoendoscopy not only to define this lesion, but also guide your endoscopic eradication therapy, predict what the histology is for that specific lesion. In this patient, we proceeded with performing resection using multiband mucosectomy technique, and histology was consistent with intramucosal cancer. The point that I'm trying to make with this slide, again, is to focus on a high-quality examination and recognize that the vast majority of recurrences that you're going to see in your clinical practice can be managed with endoscopic eradication therapy. What else is important in terms of management of these patients? When you bring them back is really based on their baseline histology. So for a patient who started off with high-grade dysplasia or cancer, our guidelines recommend that you bring these patients back at 3, 6, and 12 months after you've achieved complete eradication, and then on an annual basis. For patients with low-grade dysplasia, once you've achieved complete eradication therapy, bring them back at 1 and 3 years after eradication. This slide really is meant to highlight some of the knowledge gaps that we have in terms of management of these patients once you've achieved complete eradication therapy. Are we ready to have these artificial intelligence platforms that allow us to identify patients with Barrett's-related recurrence? Are we ready to use a personalized approach that uses clinical, demographic, endoscopic factors that allow us to better risk stratify these patients? Can we add biomarkers to this risk stratification tool to guide our surveillance intervals? And then finally, can we use anti-reflux surgical and endoscopic techniques to reduce the rates of recurrent Barrett's-related neoplasia? And in these last few seconds, I'll just talk to you about where the field is going. The Dutch group has already published a paper identifying a risk stratification tool, a prediction model using identified risk factors for recurrence, and validated this model for predicting recurrence after you've achieved complete eradication of intestinal metaplasia. We've decided to take it a step further. We used the TreatPE database not only to build a model to allow us to identify patients who are at risk for recurrence, but imagine if you could actually put in all the information that's related to recurrence of Barrett's-related neoplasia into this tool, and it actually tells you what your risk of recurrence is. And it also gives you a heat map to tell you when your patient is most likely to have a recurrence so that you can focus your endoscopic examinations at the time when the patient is most likely to have a recurrence. That's where the field is going in terms of providing a personalized approach for patients who've achieved complete eradication. I'll shamelessly put in a plug for the SERVANT trial, which is a randomized controlled trial that really will answer the fundamental question on how we should manage patients with confirmed low-grade dysplasia. Of course, we're going to identify which technique is better for managing these patients, but we'll also be looking at biomarkers, patient-centered outcomes, and also look at factors that are associated with the recurrence of Barrett's-related neoplasia. Incredibly grateful to NIDDK and all these 27 participating centers. So if you have a patient with confirmed low-grade dysplasia, please consider referring your patient to one of these participating centers. The SERVANT trial was also leveraged for another study, which will look at biomarkers that are associated with recurrence of Barrett's-related neoplasia. So in conclusion, conclusion, hopefully I've shown you that recurrence after endoscopic eradication therapy is fairly low, especially when these patients are managed at expert centers. In 2024, ensure that all these patients are enrolled in surveillance programs so that we can identify patients with barretts-related neoplasia. The single most important intervention that you can use in your endoscopic practice is a high-quality examination. And lastly, please consider committing yourself to these quality indicators that have been established for endoscopic eradication therapy. Thank you so much for your attention. Do you want me to stay?
Thank you so much. That was awesome. And our next speaker, Jason Samarasana, is going to talk to us about AI.
Thank you so much to the AFS for this honor to speak, and from this wonderful audience. It's a great meeting, and every time I've come, it's just opens my mind up to so many things. Such and never easy to follow you.
It's hard to follow.
Yeah. Sure.
The question of surveillance timing after eradication, you sort of started with leaning toward maybe we should extend the times, and then you showed a case that was several years out. Yeah. What is your current thoughts on that?
Yeah, I think two important points. I think we do way too many endoscopies for these patients. That's number one. But I think the point that you're trying to make is that your patient is never really necessarily out of the woods. The point is that don't stop doing surveillance exams. And of course, we need to use our common sense in terms of how sick your patient is, how many comorbidities. There is a model that's been published that really looks at when surveillance could potentially be stopped, not validated as yet, but it really accounts for the Charlson Comorbidity Index and age. So I think we need to, again, move away from this cookie cutter approach to managing these patients and keep our patient at the forefront of how we make those decisions.
So Sachin, just another just curious, I know we do too much endoscopy, but was there some data that actually had a skip 9 months versus 6? I know 3 is very critical in 1 year. Was there something about skipping 9 months in the every 3 month algorithm we're used to?
And again, this is based on modeling data that Kerry Cotton and Rehan Hadri did using the US and the UK RFA registry, again, making that same point that 9-month endoscopy is really not required. I know I was not a part of the M dysplasia trial, but that's how it all started, right? They were doing all these endoscopies every 3 months for a year, and then when they looked at the data, it really made no difference in terms of detection of Barrett's-related neoplasia.
We've got 1 minute. Apparently Jason broke the internet, and so we're just waiting for his videos to download.
Okay, well, we can take questions from the audience. For Dr. Nwani, anyone?
Hi, thank you. I appreciate the talks, and I think they're all such important, talks, because so much of our time is spent in the post-ablation following these patients, and it's important to sort of tool down on what is really important to do with those exams. Could you talk to the endoscopy itself and concepts of actually changing where we're doing the biopsies, whether or not it needs to be done at all the levels previously where the dysplasia was? Because I know there are concepts of actually changing that as well.
Yeah.
You want to repeat some of the question?
So the question, I guess everyone heard the question, right? I'm sorry I was not able to talk about the sampling protocol, but the stopwatch is fairly intimidating, and Reggie's emails were like, you got to stay on time. I can't go even a second over, so I apologize for not covering the sampling protocol. There's a clear divide in the way the Dutch group practice surveillance sampling compared to what our US guidelines recommend. So at least in the US, we still believe in sampling the neosquamous epithelium, and we focus really on the distal 2 to 3 centimeters of the neosquamous epithelium, the gastroesophageal junction, and the gastric cardium. So first and foremost, as Felice, you brought up, one of the most important principles is high quality exam. Look for visible lesions. That's the first step. And if you find a visible lesion, that needs to be targeted with your biopsy forceps or resection. And then once you've done that, then you take biopsies in a 4-quadrant fashion in every 1 centimeter in the neosquamous epithelium with biopsies from the GEJ and gastric cardium, recognizing that most of the times, more than 99% of these biopsies are not going to demonstrate any barretts or barretts-related neoplasia. But that's where we are. I don't think we will, this is just my personal opinion, we will ever be at that point where we are going to recommend against sampling after you've achieved complete eradication. But I'd love to hear what other experts feel about this.
We're going to discuss that in the case.
So Jason, I think this just built the suspense. So we're super psyched. We have your slides. Take it away.
So much. So I've been tasked with talking about Barrett's esophagus and artificial intelligence. And I think we'll all agree that that's a beautiful picture of a dysplastic nodule in Barrett's. And this is a 1080i image. It's not 4K, it's not 8K. But I really believe endoscopy has reached the limits of human visual capacity. I don't think seeing more pixels will actually improve our clinical diagnosis. So really what's next for elevating the care of our patients with endoscopy? And I think really artificial intelligence is going to be the next step. We keep on talking about high quality endoscopy and the high quality exam. And I think high quality endoscopy is a composite of really 3 skills. One is understanding the biological, socio-demographic, and clinical factors surrounding the case. The second is the technical expertise and manipulation of the endoscope and adjunctive instruments. And the third is the real-time interpretation of the visual matter displayed on the screen. And I think the third part is actually the hardest and hardest to teach. When we talk about endoscopy in a Can you advance the next slide? When we talk about endoscopy with real-time interpretation, especially during a screening exam, there's really 2 tasks that we're doing. Task 1 is sort of red flagging, where we're detecting areas that are suspicious for neoplasia. And task 2 is characterization, where areas of suspicion are interrogated and you're making kind of a mental calculation of what the neoplasia probability is made. So, but it takes a lot of time to look at a lot of Barrett's cases to understand that that's an invasive cancer that we're seeing there that's depressed. And you need to know a lot about squamous cell carcinoma to know that that schmutz in the proximal esophagus isn't schmutz, it's actually a cancer. And we've been doing colonoscopies for decades without realizing what we're seeing there under that mucus cap is actually a polyp. So the question is, can you take that experience of a group of endoscopists and train an algorithm to help assist with this interpretation? And you can. And for task 1, that's called computer-assisted detection, or CAD-E. And for task 2, that's called computer-assisted diagnosis, or CAD-X. Because within a group of endoscopists, there's going to be people that are better and worse at that particular endoscopic task, and there's going to be people that are experts. And so if you can train the algorithm to be to the level of the expert, and then train the other endoscopists to use that algorithm effectively, then you could potentially raise the quality of the endoscopy and lead to a better clinical outcome. So can we use AI in Barrett's esophagus? I think we can all agree that the general training for dysplasia detection in Barrett's is just not there for our US programs. I think people will admit that they're great at finding colon polyps, but finding dysplasia in Barrett's is just much more difficult. And so for Barrett's, there can be CAD-E, where you can detect a lesion, and CAD-X to characterize it. So this was one of the first continuous real-time AI-assisted algorithms that we developed. And at first glance, it may not be totally apparent where the dysplasia is. And now you've got this very obnoxious box telling us oh, look over here. This is probably abnormal. And now, when you look at the box, you can kind of see, I think a lot of us can see that, yeah, this area is definitely dysplastic. But you show this to some general endoscopists, you show this to some early trainees, they actually can't see this. And so this is sort of the idea, bringing your attention to an area so you can look at it more, take your time, and focus and sort of make the decision for yourself if there's something going on there. Professor Bergman in the Netherlands has done a lot of great work in this area, and this is one of the first real-time pilot studies. It was a small study, just 20 patients, 10 with non-dysplastic Barrett's and 10 with Barrett's neoplasia. But essentially, this stuff is working. Accuracy, sensitivity, specificity, pretty good. But let me show you how far things have come in a few short years. And so this is work by Professor Messmann in Germany. And now you can see, the interface really isn't as loud and as obnoxious. You're seeing this sort of very sophisticated sort of masking with almost like a transparent kind of cap that's sort of over the lesion, and very, very precisely kind of pointing out the areas of concern. And I think this sort of interface is just, very kind of pleasant, easy to work with. Of course, you're seeing, really great quality endoscopy, very slow movements, very stable. The mucosa is extremely clean. Here's another prototype looking at a different type of masking where it's almost this sort of, coloring over the areas of concern. And there's a lot of different types of, features or kind of ideas in terms of how to highlight, high-risk areas. This is almost like a spotlight. Here we can see a really beautiful example of the AI picking up an area of concern that's very flat and very subtle. And so this is sort of kind of what we're going to be able to do. One of my favorite videos is this one. So this is, again, the same algorithm, but you can see here on the left, there's actually a little motion detector. So as the scope is being moved, you can see it register, how much motion is happening on the image. And I think, again, getting to that high-quality exam, keeping the scope still, and this is sort of giving you now feedback to the performance of the endoscopy, not really detecting anything, not really characterizing anything, but just sort of giving the endoscopist feedback as to how they're doing during the exam. This is a post-ablation surveillance session, and as far as AI and computer vision algorithms, really there's not much data at this time. And I think inspecting a Z-line after ablation to evaluate for recurrence of IM or dysplasia, may be possible one day. But I don't really see this being the place for AI right now. I think, surveillance before ablation is really the sweet spot for CAD-E and CAD-X. Really, the general endoscopist really hasn't had adequate training in dysplasia detection or the performance of a high-quality exam. As much as we've tried to train and retrain physicians to do this. But I think with AI, CAD-E will draw the endoscopist's attention to high-risk areas, and CAD-X can characterize the risk. But I really would love to see AI focus on assisting the endoscopist with performing that high quality exam. You know, this stilometer or this motion meter, you know, making sure a cap is on the scope when you're doing the exam, you know, ensuring adequate cleansing of the mucosa, and then slowing things down so you increase your Barrett's inspection time. But a word of caution about AI is we really can't ask too much of AI and computer vision algorithms. We'll see that companies really only focus on algorithms that have commercial viability. You know, because of the way the regulators work, the nature and content of a training set is rarely disclosed. And training sets, having worked on multiple algorithms now, are highly biased on these non-subtle lesions and classic presentations. So just because an AI algorithm can find a nodule in the tubular esophagus doesn't mean it can actually find flat dysplasia at the Z-line after CRIM is reached. So I think, you know, the emphasis really for the academic groups now should be to focus on algorithms that actually make the endoscopists better endoscopists, and really focus on things that help improve the performance of the high quality exam. So using a cap, reducing motion, cleaning the Barrett's, and then slowing your exam down. Thanks very much.
Thank you. That was very cool. Our next speaker, Dr. Neil Sharma, is going to talk to us about refractory disease.
Good morning. Thank you to AFS, our course organizers, Dr. Smith, Dr. Bell, for inviting me in the panel I get to follow. Hopefully I'll get the slides to work. Jason, way to hang there. Tough. So I'm supposed to talk about what is a difficult topic, endoscopic therapies for eradication of refractory disease. So I think before I even get into the details of how we would approach this complex topic that I think all of us probably on the stage have been referred second opinions for, it's important to define really what the problem is, right? So anytime we talk about a complex problem, we want to define what the problem is, understand what are the factors influencing that problem itself, and then we can talk about what are some of the modalities that may be helpful to be able to achieve the outcome that we want to achieve. So, you know, I got to train with Nick Shaheen. I remember a lot of patients getting referred for refractory Barrett's, so we'd have to try to figure out what does refractory Barrett's really mean. And when you look at the literature, for the most part, this means patients who have not responded to radiofrequency ablation, which is the most common modality for the treatment of Barrett's. So what is a response to radiofrequency ablation? And this could be debated quite a bit, but for the predominance of patients, they're going to have short segment Barrett's, which is 3 centimeters or less, with dysplastic disease ideally that's being approached with radiofrequency ablation. And it should respond in most cases in about 3 to 4 sessions. And if it's not, we may define this as refractory disease. Now, of course, the length of the amount of disease influences those number of sessions, and there are other factors as well. So let's look at those factors. So in a multi-center study back in 2013, the first tried to look at some of these factors, one of which is really important and probably sets up the next talk with Sri, which is active reflux esophagitis. Another one is the scars that regenerate after we do areas of piecemeal resection that may create a barrier to radiofrequency ablation. Additionally, some pre-RFA esophageal diameters, particularly when it's very narrow, can influence the ability to make the type of contact that we want because it's a contact-based modality. I would argue that even really patulous areas or areas that are kind of not smooth, so it's harder to get the contact we want for RFA, would be potentially influential as well. And then longer years of dysplasia presence, which kind of echoes some of the work that Dr. Wani was talking about previously. These are all independent factors for poor response to radiofrequency ablation. Additionally, there's some other factors that we've now defined, and you can see some of the references later on at the end of the slide deck, but the presence of a hiatal hernia, which is why we're here in a multidisciplinary format, is something that contributes to the limited response to radiofrequency ablation. Advanced patient age is also important. Long segments of Barrett's esophagus that I mentioned previously. Incomplete healing when we go for subsequent endoscopy. So if you go back down between RFA sessions and you see an area of maybe unhealed mucosa, inflamed mucosa, ulcerated mucosa, that's something to be very cognizant of, and maybe you want to back up and take a look and make sure that patients are actually getting adequate reflux control or you're getting the type of response you want. And then, of course, procedural volume, which is something that was echoed again by Dr. Wani in the beginning. If you're doing 3 or 4 of these a year, of course, you're not necessarily expected to have the same outcomes to someone who's doing this much more often, right? So I think before we get into the details of some of these new or novel modalities for refractory disease, I have to at least talk a little bit about controlling acid reflux. And I won't get too much into the details because I don't want to steal Sri's thunder, but certainly not controlling the reflux makes an environment that's not going to respond to radiofrequency ablation. I think before you start to jump to other modalities, you have to ask yourself this question: have we controlled it? So for most of these patients, they're going to be on PPI once a day. But depending upon their symptoms, you may titrate that upwards to BID. And still, even then, these patients might not get adequate acid control. And that's where you're reaching across party lines, talking to your foregut surgeons and saying, hey, maybe we need to do something else before I go down this pathway of repetitive radiofrequency ablation. And when we take a look at acid control itself, we have to make sure that the patients are taking the medicine correctly, which again, may be talked about more in the other lecture, but that often happens to be the case. They're taking it with other medications, it's not getting its adequate bioavailability and so on. And then when you maximize them to BID, at least 90% of the time that's going to be efficacious, and you can go back and try RFA again. If that doesn't work, switch to other modalities, which we'll focus on. For some of those patients, even at BID PPI, it's just not enough, and right? So we need other surgical therapies that may help us, or even endoscopic therapies that may help us control that acid environment so that we can have the outcomes that we expect that were noted before for radiofrequency ablation. So now I'm going to turn to a couple of different modalities that could be helpful for you if RFA has truly failed. So one of which is spray cryoablation. We've done a lot of research. I personally participated in some of this research. There have been 3 studies. They're a bit dated now, but that have taken a look at how can patients with refractory barretts that have had this complete maximal acid control and they don't respond to radiofrequency ablation respond. And you can see the eradication of dysplasia is a bit variable and maybe not as high as what we'd expect with RFA. In these studies, and this is a composite set that I put together for you, it's 75 to 83% eradication of dysplasia itself, which is probably the most important factor. When you look at complete eradication of intestinal metaplasia, it's even lower, 31 to 50%. Now, we had embarked on a study that we've kind of paused on now, back in Indiana, where we're trying to take a look at what if you increase the dosimetry. So one thing that's nice about spray cryoablation is it's not a set dosimetry like you have with RFA, right? You can actually increase the amount of time that you actually spray that area, and you can bring them back more frequently, both of which can increase the amount of dosimetry that you're delivering to this area. And the thought behind that is spray cryoablation can penetrate deeper, perhaps the deep submucosa even, to be able to get the outcome. So I think that needs to be investigated further because, of course, most of us are not going to accept these type of numbers as being adequate for treating refractory disease. Balloon cryoablation, which is getting more popular. So it's nice, right? You don't need a capital expense. You put a balloon down, the balloon insufflates, so it's not as operator dependent as spray cryoablation. Of course, I think it's important to understand that dosimetry can't be varied with the balloon. Additionally, we're not comparing apples to apples in terms of how cold you're getting. So negative 78 degrees Celsius versus spray is negative 196 degrees Celsius. And why is that important? We have to understand when we're going to secondary technologies, what are these technologies trying to do? How do they work? And what is the outcome we're trying to achieve? And so, we're trying to get deeper penetration. And so perhaps it's not apples to apples here. There is no data right now on refractory disease with the balloon, but there is a study, and I tried to mention the study that's pending, and I think it'll be important to look at that data and understand maybe that this is a modality that we can utilize in the future. Additionally, hybrid APC. So I can tell you we're looking at this data. We're part of a trial that got stopped in Indiana when I was there. There is strong data from Europe for its use. If you take a look at its first-line use for Barrett's esophagus, does it work? And there is greater than 90% overall complete eradication of intestinal metaplasia in Europe. There is a stricture rate. So how does this work? You inject fluid into the submucosa, you use APC, and you basically destroy that area, getting deeper penetration to the submucosal layers, which you don't typically get with RFA, which is limited usually to the basement membrane. You can get some strictures, and you can get some SAEs. We've not extrapolated this really to refractory Barrett's, but there is one study right now that's published in the literature. It had only 5 patients. But it worked well. They said all 5 patients responded without any serious adverse events. So maybe this is also something that needs to be studied. And being at this talk particularly, I think it's important to understand, where are the opportunities for us to advance the science, particularly in this area. So Arvin Trinidad published this algorithm. This is the one algorithm that's out there relevant to what happens if patients have refractory disease. So I can see some of you taking pictures. I'll pause here. This is exactly what I've talked about previously in the study. Take a look at these patients, define that they truly have refractory disease, try to maximize acid control. You can do it with medications. If they don't respond to medications, look at other therapies, surgical, endoscopic therapies to create the barrier. Go back to RFA. If RFA is not working, look at these secondary modalities, which include spray cryoablation, perhaps being in a trial for balloon cryoablation, or looking at hybrid APC. I think the one thing that this is missing, and this will be my last slide, is an area that I do a lot of work on, which is endoscopic resection. So it's not in that algorithm at all, but this is certainly something that we do quite a bit of, right? So you've already seen pictures of EMR and a video of EMR that Sachin showed very nicely. But I think ESD also has a role in here, and we published some studies on what does ESD do in the setting of Barrett's. EMR can be done for focal disease, multifocal or wide field that you saw in the video with Sachin. ESD can be done even circumferentially. And then there is a study looking at endorotor, which is actually a device that goes down and kind of basically mucilates all of the tissue and the mucosa, and the pros and cons of doing that as well. But I think this needs to be eventually added to the algorithm because this is being adapted more and more, both in Europe and the United States. Thank you.
Thank you. And now we can welcome Sri back to the podium to talk about when to fix the reflux barrier before, during, and after his perspective.
All right, perfect. As you can see, I did change the title a little bit. I thought it was a little heavily biased towards our surgical colleagues here, but as a gastroenterologist, I wanted to make this a little more objective. So, I do want to start and echo, if we're really focusing on a tree and not the forest, and if we step back for a minute, it happens to be the 20th anniversary of radiofrequency ablation. I don't know if we have a party planned for that, but I would say we don't, and the reason is, we've done nothing in terms of the incidence of esophageal cancer. And that's kind of sad for all of us who've been ablating many people for 20 years. But that incidence hasn't changed. And so we are amazingly effective at treating the limited disease we see, but we're treating a disease that we actually can't find. And I think that's a very critical piece to the entire puzzle as we get into this. And as we focus further the lens, we're here to talk about post-eradication. And again, we're treating a very small subset of the patients. Our denominator is very low. Anytime we approach this, we need to think about the continuum, and I think it starts with reflux and it ends with reflux, and we're going to talk about what it is that's been demonstrated here so far that's critical to ensuring eradication, but durable eradication. And I think the idea, when we think about this process and we start with reflux and it develops into Barrett's and neoplasia and we embark on endoscopic eradication, we then, over the last 20 years, many of us have learned, really have witnessed the natural history of this disease because we eradicate it in an environment where the physiology is not well controlled, and we start to see the process evolve all over again with esophagitis all the way through Barrett's and forward. So again, and I always say this is not rocket science, this is reflux driven, and it will be reflux driven again. And so I think the idea that we can continue to sprinkle PPIs at high doses to cure and prevent recurrence and disease is very futile. So we need to think, and I'm sitting next to Sachin, who's a good friend and the master of our guidelines, and if you look at the guidelines, one of the areas we're very weak on is in that post-eradication segment, not about surveillance. You saw many, many pieces of guidelines around surveillance, but not looking back at the physiology and management of reflux. And I think that, and I don't say that as a misstep for the guidelines writer, it's for us as practicing gastroenterologists, because often we will see these patients and they will say, I have no symptoms, and we will not address anything further with reflux. But guess what? We're okay with pulling out the RFA catheter and doing 12 more ablations because that spot's not going away. So that's where I think we become foolish. So our expertise in therapy is clear. We are fantastic at resection and ablation. I will say a lot of this session could go away, in my opinion, with very basic fundamental improvements. We talked about a high quality exam. We're looking for fancier. It's a very a mentality of this era that we always want new technology to take the place of hard work. Right? It's the idea that inspection is now going to be replaced by what Jason showed us, which is probably the right way. It's like our kids on our cell phones. We get angry with them, but that's the era that we're living in, right? It's an AI-driven era. Diagnostics will disappear, and we don't have to be as good of an exam. Same thing with resection. We talked about ESD and EMR. Why did ESD even get into this picture? Because we would look at these segments and not do a good exam, and we would resect small areas. And now we understand we need to do a proper wide margin resection. And a lot of these recurrences don't come about if we actually focus on those very basic steps up front. So one of the problems here, so we know that, as has been shown, we're very good at eradicating this disease. We still have some degree of recurrence, which is dropping. And it's dropping because we're becoming more careful. It's because we're inspecting better. We're focusing on fundamentals in resection and ablation. And more importantly, we're focusing on reflux. This is the guidelines. I won't go over this. Is what Sachin pointed out. So this is a very typical patient that we see, and we treat them for Barrett's-related neoplasia with EMR, RFA. We biopsy them, and we say, hey, you're eradicated, and then everything's done. And I think that's where everything begins. I think when I train our fellows, some of the most important inspection that they need to do is after eradication. Finding those little islands that we subsequently say, hey, I saw nothing, and we biopsy and you still have Barrett's, is not really a recurrence. It's because you didn't do a good job treating them in the first place. So I think a lot of these things are very simple solutions that we're making extremely complex. The physiology of this is not complex, but we're taking a pie that may be very simple and making it very complex. So ultimately, in this scenario, we're telling our patient they're cured, you can stop PPIs. We tell them your Barrett's is eradicated. To prevent recurrence, you should have an anti-reflux procedure and continue surveillance based on pretreatment pathology. Or C, you are lucky. Many patients have BE refractory to EET that need alternative strategies. And endoscopic surveillance can be stopped after 3 years. Now, this is a little bit of a facetious question. There's some truths and non-truths to every one of those statements. So all of these are technically right and wrong. But it's critical to really set the stage. And some of the options we have to what I call closing the door, right? So a lot of the issue, and this is a very refined population that has the worst reflux, and this is a mechanical barrier issue. This is not a let's throw gallons of PPIs into the stomach and hope this stops the problem. It's very simple. The door is wide open and we got to close the door. And I purposely did not include a Lynx picture here because I wanted to give my GI colleagues some support with the imagery of the TIF procedure here, but that's just for fun right now. One of the things I want to back up into is the idea of what is refractory, because again, we are in an era where we have to set a threshold whereby we look at physiology and understand where do we sort of make this, the timing, or where do we sort of intervene when it comes to mechanical barrier reconstruction. And this was a study we looked at from our TREAT-B cohort, and it really kind of highlighted what we've shown and what everybody said, and that we've always talked about this magic number of 3 to 4 sessions for eradication. And this kind of highlights that that's true. And when you reach that threshold, what ends up happening is this. And these are some of the original work we did years ago, highlighting those refractory, quote-unquote refractory patients. They're asymptomatic on twice a day, 3 times a day, 10 times a day, PPI, doesn't matter. It doesn't make a difference. They still have bad reflux. The door is open, you got to close the door. It's not rocket science. And this is pH impedance testing at the time, whether it's bile reflux, whether it's weakly acid reflux, it's reflux. It's stuff coming up and down. And stuff coming up and down causes the disease, causes neoplasia, causes all the discussion that we're having today. One of the things we presented at DW a couple years ago was just a retrospective look back, and this is being prospectively written, but the idea in a large cohort of our patients, 114 who had endoscopic eradication therapy, and we compared those who had anti-reflux surgery and those that did not. At the time, the vast majority were both fundoplication and some links, and this is a very heterogeneous and not well designed because it's retrospective, but very simplistically, that complete eradication in our large cohort of 97% in patients was maintained and durable in those who had anti-reflux procedures versus 84% that did not. And ultimately what we've shown in this and others is once you correct that mechanical barrier in these refractory patients, it's extremely simple to eradicate Barrett's neoplasia. And we have sort of internal control data. We do a lot of links and TIF now for this situation. And none of these patients to date recur, and that's not a very scientific statement. I know that. He'll kill me. But the point is, we have this, and we need to look at this, and there are studies ongoing to outline this. So what have we learned in our experience at Northwestern and with endoscopic eradication therapy and GERD? Patients who are refractory to EET or have an incomplete response generally have an uncontrolled reflux burden. And that's a lot of it is on us as gastroenterologists to understand that physiology, to work with our surgical colleagues and understand that just having a patient tell us they're asymptomatic is absolutely not enough. When patients are treated with a standardized anti-reflux reflux management protocol, And this is really staying on top of them as gastroenterologists. We do, as Sachin mentioned, we do all these endoscopies, and we do very little time with the patient. We do this in our protocol, but we give them a GERD cue. Do we actually assess their symptoms properly? Do we look at adherence and compliance on medication? Not just that they're taking it, are they taking it appropriately? One of the things we learned is that in our study in the Red Journal, 63% of patients have their PPI dose adjusted or completely stopped during endoscopic therapy by their third-party payer or their primary care physician. So if you don't pay attention and just say, hey, the patient's coming every 3 months, we'll just copy the med list from last time, it's fine, right? Or it's in the EHR and it's not adjusted, you could have a problem. Ultimately, we talked about this being a physiological reflux issue. And of patients who have completed endoscopic therapy, one of the things we presented in 22 and is being written up now is there was absolutely no difference in complete eradication, recurrence of intestinal metaplasia, despite PPI type, dose, or frequency. So it didn't matter if you bump these guys up to twice a day, once a day, use Dexilant, Acifex, whatever you want, it doesn't matter. Again, the door is open, you gotta close it. So what have we learned? In patients who undergo endoscopic therapy for Barrett's-related neoplasia, mechanical barrier correction should be considered for signs and symptoms of uncontrolled reflux. I'm going to skip this. So what does that mean? So who are these people we need to really look at carefully? So it's, again, quote-unquote refractory patients, some of these who are not responding or who are requiring more than that kind of 3 to 4 sessions. I think the key message to us and our gastroenterologists who are doing so much ablation in the community is when you continue to ablate a patient and they're not responding, you need to stop and look at their physiologic parameters and see if it's an anti-reflux procedure they need. Obviously, erosive esophagitis during therapy and recurrence, and exactly what we're talking about here, after eradication, if they do have recurrence, this is a sort of a red flag to say, hey, you need to look at their physiology and see if something further needs to be done. So this is the final kind of component of this. So we decide they need an anti-reflux procedure, who gets what. There's clear sort of pathways, and we're evolving in this thanks to all the surgical and endoscopic collaboration. A patient with a large paraesophageal hernia, a lot of these sometimes we correct early on. Surgical fundoplication is still there, but then on the other side of a traditional hernia, depending on, and we can have hours of conversation, I'm sure, with the surgeons and ourselves about the role of high-resolution manometry in this decision-making, but at least gives us a little bit of a starting point, and this is where we make a distinction between a CTIF and a LINX to move forward. And some of this is obviously dependent on the patient. One quick point, as you know, there was an FDA expanded labeling for LINX directly related to Barrett's esophagus. So this takes away some of the headache from our surgical colleagues who are limited. Now we can use this in the Barrett setting. And so lastly, I think it's time to think outside the box. There's a couple components here which it's always hard for me to stay focused on the post-eradication because I think we're very passionate about the bigger piece, which is we have to expand the denominator of patients we're treating. And that is 100% about screening, and that's what you're going to hear about later in this meeting. It's about screening patients who are obese and not looking for symptomatic reflux. If we continue to look at symptomatic reflux, we're never going to solve the esophageal cancer issue. And lastly, sort of that correction of the mechanical reflux barrier for refractory, recurrent, or uncontrolled symptoms during EET will prevent this issue and the need for unbelievably large amounts of endoscopy that we don't need to do. So the slide that I always have, and I'll show it for the last, it's approaching 12 to 15 years, but so this is my vision. It's that we'll soon live in a world where all patients will be screened for Barrett's in their primary's office with an inexpensive in-office device, started on a PPI therapy and referred to a GI if positive. These patients will undergo high-quality endoscopy and treated if they have endoscopic evidence of Barrett's. Upon completion, they will undergo biopsy to confirm cure, a surgical/endoscopic anti-reflux procedure shortly thereafter. You'll stop their acid medicine and recommend yearly non-invasive surveillance by their PCP. You will give your patient a hug, wish them a great life, and part ways know we finally cured esophageal cancer. Thank you.
Thank you. And next we have Dr. Tom Watson, who is going to talk about reflux surgery after ablation.
Can we reset the timer, please?
So thank you, Chrissy. Thank you, Mike and Reg, for putting together this wonderful program and for inviting me to come speak. It's really an honor to get to follow up on the heels of my esteemed GI colleagues here. And it's my task to give the surgical perspective a little bit about the role of anti-reflux surgery. And I was tasked specifically with following endoscopic ablative therapy, but as Shri talked about, it's really a continuum, whether you treat pre-EET or during EET or post-EET. I think there's a lot of room for judgment there. So I just want to share a few perspectives on that. Now, John Lipham spoke 2 days ago about the role of anti-reflux surgery in inducing regression of Barrett's on its own without EET. My task today is really to talk about how does anti-reflux surgery impact the efficacy of EET. So again, I don't want to belabor some of the data that was already adequately covered, but just to set the stage here briefly, we all know that we're not completely effective at eliminating either dysplastic Barrett's or non-dysplastic Barrett's, and these are some of the efficacy rates quoted in the literature. And of course, it depends on how many sessions you're giving, what kind of therapies you're giving, how long you're following people thereafter. So the literature is a little bit all over the place in terms of rates. Clearly, it's about reflux control, as has been mentioned. But anyway, there's going to be a certain amount of refractory IM. The data would suggest anywhere from 4 to 14% after up to 3 sessions. I think Sachin covered this earlier. But we also must consider recurrent IM, and as has been stated, this is a reflux-related problem. And if we don't control the reflux, either medically or surgically, we're going to have a certain amount of recurrence of either dysplastic or non-dysplastic IM, particularly the latter. Now, what are the risk factors for persistent or recurrent BE? Again, these have been covered, but certainly it's about reflux control. When there's a large hiatal hernia, that reflux can be very difficult to control with acid suppression therapy. And BE length more than 5 centimeters has been listed as a risk factor, but it's really, oftentimes those patients often have bad reflux and a large hiatal hernia. There are some unvalidated risk factors, and again, these are confounded because they're oftentimes present along with some of the validated risk factors. Patients with long segments of BE, et cetera, often have a bad GERD. So what's it all about, really? If we're going to consider a post-EET anti-reflux operation, it's about 2 things. One, it's about reflux symptoms. Bad Barrett's often is bad GERD, and people have bad symptoms that need to be controlled. It can be difficult to control with acid suppression therapy. And of course, facilitation of complete eradication. So it's all about this reflux control. So what are the considerations about timing? I'm going to say this is not a one-size-fits-all solution. It has all dysplastic Barrett's, including cancer, intramucosal, and sometimes now even submucosal cancer, been adequately eradicated. What's the likelihood that the patient's going to require an esophagectomy? We haven't really talked about esophagectomy and its role for early neoplasia, but it's still a one-stop solution for cancer. And so for certain cases, we're not using it very often anymore, like Mimi said, and I agree with that. But there are cases that are appropriate for esophagectomy, long segment, multifocal, high-grade dysplasia, some cases of submucosal cancer, recalcitrant strictures, an aperistaltic esophagus that needs to come out. There clearly are times for esophagectomy. We have to decide, is this patient going to require one? Now, we could put him through an anti-reflux operation, and if it fails, put him through an esophagectomy later, but of course we want to avoid 2 surgical interventions if we can. Are risk factors present for the refractory recurrent BE? In other words, there are large hiatal hernias, this long segment Barrett's. Is esophageal acid exposure controlled on a PPI? And Phil Katz brought up yesterday or a couple days ago the notion of going straight to PCAB therapy rather than PPIs. And we have a lot to learn. What's going to be the role of PCABs in control of this disease? Most of the data that have been shown are on PPI therapy. And are symptoms controlled on their PPI or PCAB? Again, you can completely eradicate the intestinal metaplasia, but if they're still having bad GERD symptoms, then maybe that's a reason to go through that anti-reflux operation anyway. So again, it's not a one-size-fits-all solution. This is very much a case-by-case decision. It's a collaboration between the person doing the ablation, whether it's a GI doctor or the surgeon themselves. You have to have this discussion back and forth. Why has ablation failed? Did they need cryotherapy? Did they need more ablations? Or they just need better reflux control? So there's really a lot of room for fertile collaboration, which of course what the society is all about, right? So we can suggest that we should be putting patients through an ARP to help them control their dysplastic Barrett's or their IM. What did the data suggest in terms of the actual efficacy? And again, we focused a lot on acid suppression here, but of course, an anti-reflux operation controls also the reflux of the other components of gastric juice that are potentially injurious to the esophagus, including bile, pancreatic enzymes, stomach contents of other sorts. So, anti-reflux operation controls reflux of all those components, not just the acid. But what do the data show? And interestingly, there's really not a lot of data out there And it's kind of fun to present this study because many of the authors on it are here in the room today. It's the biggest series of which I'm aware, looking at the durability of endoscopic therapy after Nissen fundoplication. And again, this is after Nissen. The last speaker was showing a slide about TIF and the links and other forms of partial fundoplication. We don't really have a lot of data comparing Nissen to those. So again, it's another area there's potential avenues for research. So this was a retrospective review presented about 10 years ago at SSAT from 4 different academic centers. And with the 4 centers, we were only able to come up with 49 cases. These were all cases treated with RFA, plus or minus EMR, then followed by Nissen fundoplication. Prior to the Nissen, again, after the endoscopic ablative therapy, there was complete eradication of IM in about a little over half of cases. There was complete eradication of dysplasia with persistent IM in about a third of cases, and there was persistent neoplasia in about 14% of cases. After the Nissen, we were able to increase that complete eradication of IM up to 70%. An additional 63% of the complete eradication of dysplasia group achieved complete eradication of IM, and 4 out of 7 with persistent dysplasia achieved CE-IM. So the conclusions were that Nissen fundoplication after EET, we hadn't needed a chance to go into this specific data, but resulted in similar durability of CE-IM compared to PPIs alone. And it was thought that a Nissen fundoplication may be superior in preventing progression and development of cancer. And again, because we're controlling all these components of the refluxate rather than just acid. The other series of which I'm aware that's sizable, it's about now 39 patients undergoing fundoplication, and these data were presented a couple of days ago as well. And again, some of the authors are here in front of me and alongside of me, which is sort of fun. But they had 221 patients in their series, 48 of whom they did not achieve complete eradication of IM after 3 sessions. So they had to modify their reflux management, and 39 patients went on to fundoplication, and in those 39, 95% achieved complete eradication of IM with no recurrences. The only recurrences, in fact, were in patients with a hiatal hernia. So again, showing that Nissen fundoplication can be a very effective way of achieving complete eradication and sustaining it in the long term. Now, I was also tasked a little bit about some of the biopsy considerations following EET and an anti-reflux operation. And as was stated earlier, there's some discrepancy about what the biopsy protocol should be. Clearly, you need to biopsy some of the neosquamous mucosa around the GE junction and the cardia. And it's generally, as we all do, 4 quadrants every 1 to 2 centimeters, et cetera. One of the things about a fundoplication is that it may alter the perception of where that GE junction is as you pull that wrap up around the distal esophagus and bury, so to speak, that columnar mucosa within the fundic wrap. It may alter your perceptions of where that esophagus truly lies. So it is important to be aggressive about your biopsies within that wrap. And there's really no data to suggest it's any more difficult to do those biopsies. All that mucosa is still available to your endoscope and to your biopsy forceps. You just have to be meticulous about going through that region of fundoplication. So some closing thoughts. The timing of an anti-reflux operation is a continuum ranging from pre-endoscopic therapy to years post. I think the timing is best determined by the goals of your therapy, and those goals can be symptom relief, because oftentimes bad Barrett's is in the setting of bad GERD, CE of intestinal metaplasia and dysplasia. The risk factors are for persistence or recurrence, especially GERD severity and the size of a hiatal hernia. The best anti-reflux operation in this setting has not been objectively determined, whether it's a Nissen, whether partial fundoplication is adequate, can we do magnetic sphincter augmentation, C-TIF, or others. And clearly this is fertile grounds for a multidisciplinary approach. So on that, I'll close, and thanks again for the chance to talk.
Thank you, Tom. And next, we welcome Dr. Shah, who's going to update us on cryo.
So, can you guys hear me? Perfect. All right, so while we're waiting for this to come up, I'll be switching gears a little bit and discussing the role of cryotherapy in managing esophageal cancer. So we're kind of moving a little bit away from Barrett's. And I'm going to try to highlight a few cases that kind of highlight, what the role for cryo may be in these folks. So case one, so this is a gentleman I recently saw who has a very long segment of Barrett's, C11, M11, with high-grade dysplasia, but within that segment, there's this 2-centimeter area of adenocarcinoma. And we did an EUS and staged it as a T1B, and specifically an SM2-3, so this is not a superficial submucosal invasion. And on PET scan, there were no distant mets. The problem for this patient is he has a pretty poor performance status. He's also on anticoagulation for recent PE. So we discussed him at our multidisciplinary conference. Our surgeons really didn't think he was a great operative candidate. And in fact, our oncologists didn't think he was a great candidate for systemic therapy either. So what are our options here? So, you have endoscopic resection, but when we're talking about SM2-3 disease, I think even in the best of hands, you're talking about a higher risk of complications, so more difficult case in a patient with pretty poor reserve. I've done a handful of these SM2-3s, and I've always had a positive margin. I mean, there's folks that might do it better, but there's certainly a higher risk of a positive deep margin. And then there's issues around his anticoagulation. I mean, do you wait and then hold it? Do you put him on a heparin drip? There's other options. So we discussed radiation therapy and brachytherapy, and their options, our radiation oncologists sort of felt, well, it's not particularly effective for Barrett's. It might be nice if you could do something that treats both. And then you have your other ablative modalities. The problem with those is they're great for Barrett's, but because of the depth of penetration, RFA, cryoballoon, APC, not really great for bulky tumors. PDT is out there, but again, it's not widely available. Living in South Florida, phototoxicity is really not an ideal side effect. So what about spray cryotherapy for these group of patients? So for BE, I think Neil highlighted some data, but we don't have any randomized trials, and we're probably not going to get any because of the large sample size that would be needed. But at least in the retrospective studies, it seems to be about equal to RFA. In our data, they did need a few more sessions to eradicate BE. One of my former colleagues, George Smallfield, actually did a really nice prospective study where he found that cryotherapy actually was associated with less pain compared to RFA, so that's kind of a nice little advantage there. And then moving on to that T1B esophageal cancer, we do have some retrospective data, and in that data, cryo seemed to be about 60% effective at completely getting rid of the tumor. Now, I think there are some caveats. It was retrospective. The data did not distinguish between SM1, which is much easier to treat, versus SM2 and 3, which is this patient. But it sort of mirrors my own experience before I was doing a lot of ESD, that's sort of 50 to 60% complete response rates. One of the other nice things about cryo is you can, ideally I do it off anticoagulants, but I have done it, on anticoagulants. So for this particular patient, he's on his second session. My goal is if we can get that tumor completely ablated, then we can even switch to a multimodal approach with RFA to kind of eradicate that longer segment and maybe even cryoballoon if needed. So the next case is a gentleman, 77-year-old patient who was experiencing dysphagia, had an endoscopy which identified an esophageal adenocarcinoma. There were no mets on his PET scan, but on EUS this was staged as a T3N0, so clearly a more advanced cancer than the ones we've been discussing earlier today. And the plan for this patient was neoadjuvant chemoradiation using the cross regimen. So the question is, what options do we have to palliate dysphagia in this particular setting? So esophageal dilation is an option. Some downsides would be it's a transient dilation effect. There's really no debulking or tumor ablation, although you could argue that chemoradiation is eventually going to do the heavy lifting there. Again, we talked about RFA, cryoballoon, not really great options for bulky tumor because of their superficial depth of penetration. What about esophageal stents? They work great initially. Everybody has dysphagia relief, but there are problems. So there's the minor side effects, chest pain, GERD, stent migration. I think those can be managed pretty easily. If the stent is traversing the G junction, aspiration pneumonia can be a problem, and I think that's more problematic. And then the cases, I've been seeing more of these lately, and they're really devastating, are tracheoesophageal fistula. And recently I had an aortoesophageal fistula where the patient actually bled out essentially exsanguinate around the endoscopy suite never want to have that experience again. So, I mean, esophageal stents have a lot of problems. So that kind of led us to say, well, can we use a spray cryotherapy in sort of this neoadjuvant setting? So we did 2 separate trials, both of them pretty small. Both of them had 14 patients each. So in the first study, we did the first session, just 1 session of spray cryo during the staging EUS. And then after that seemed to work pretty well, we did another study where we tried to dose escalate and gave up to 3 sessions before neoadjuvant chemoradiation. And the sort of, what was encouraging was there was no grade 2 or 3 toxicity, and most patients had improvements in their dysphagia and quality of life. And what was really neat, but this really needs to be validated, is that we found that more than 50% of the patients had a long-term complete clinical response. Normally with chemotherapy, radiation, the cross or FLOT regimen, you would expect that number to be 25 to 30%. So again, this needs to be validated further, but boy, wouldn't it be cool if you had a treatment that improves dysphagia, minimal morbidity, and is synergistic with chemotherapy and radiation. So the last case is really kind of the same patient. He unfortunately did not have a complete clinical response. He declined esophagectomy, and so he was started on nivolumab. And the question then comes up is in this group of patients who are not operative candidates or not getting an operation, is there any role for cryotherapy? And so there have been a few retrospective studies, and more recently, Dr. Kashami published a prospective multi-center study, which we were a part of. In this study of 55 patients, 80% received concurrent systemic therapy. And again, spray cryotherapy did improve their symptoms, their dysphagia, and quality of life. One of the things we learned, I was actually doing cryo every month or 2. Other centers were doing a more intensive regimen, which they defined as 2 sessions within 3 weeks. And they actually did a lot better than I did in terms of dysphagia improvement without sacrificing, without an increase in toxicity. So to summarize, for the group of patients with really long segment barretts, with multinodular cancer, who are not great surgical candidates, and you can't kind of resect each one of these pieces, spray cryo might be a good option for that group of patients. For locally advanced cancer, prior to neoadjuvant therapy, I've been doing spray cryo for more than a decade. I think it works great. And then in these patients with inoperable cancer, spray cryo does seem to improve quality of life, and it does seem to be safe to administer along with systemic therapy. So I'll end with a couple of pearls. So for debulking, again, based on Dr. Kashami's study, would suggest trying to schedule 2 sessions within the 3-week period, being a little more aggressive up front. That can be obviously challenging, so it's easier if you schedule these patients 2 or 3 procedures out in advance, so you don't run into finding a spot for them scrambling to find a spot. You can administer, I typically will hold anticoagulant if I can, but if push comes to shove, you can, in these high risk for thrombosis patients, administer cryo while on an anticoagulant. And then for spray cryo, you have to pass a decompression tube and a scope, and with a bulky tumor, you can quickly run out of real estate. So one option is actually to use an ultra-slim scope. For the Olympus scopes, that would be the XP scope. And the spray catheter actually fits through the working channel, so you can actually use a thinner scope. Thank you.
Great. These are all great talks. I think because of the little glitches we had, I'd like to go to the case discussion. Please open your apps and put the questions through the app, and Mike's going to monitor them. But I want to just actually highlight some of the points we've had in the discussions. I probably should sit down.
While we're waiting for that to happen, my phone is blowing up, and I have to represent the surgeons on some comments here. And that is regarding anti-reflux surgery and the timing of RFA. As we move forward, I love the fact that we're all recognizing that we're improving outcomes by incorporating anti-reflux surgery into the algorithm. The 2 studies you show that it is a continuum and that we should be working together, but there are some concerns about TIF in this situation. Not only are you putting a proline dart through a potential cancer that's going to be full thickness, there's some concerns about that. The other thing that surgeons consider when going down this algorithm is, what if it fails and we do have to proceed to an esophagectomy? And Fundoplication will increase the risk of having a poor conduit for an esophagectomy. And TIF, none of us like redoing TIFs. We don't have the data, we don't know. There's also an opportunity to do a toupee or a bypass in patients that need anti-reflux treatments. And so we just want to make sure that we are all collaborating in this algorithm as you go down the path of should we add anti-reflux surgery to someone who's failing. Please consider the surgical approaches before doing a TIF.
Yeah, no, so great points. Christy, I just want to mention that we do have a post-ablation Barrett's esophagus trial. It's really a pilot exploring that possibility. And I think in that setting, it would potentially only be entertained when you have a complete eradication and it seems to be durable and you're not going through Barrett's. And
totally. So then you're just treating GERD. Then it goes back to the algorithm of they're done, they're happy, the mucosa's healed. Totally.
Yeah, no, so
totally
but
get that.
Again, I think this is really nice about this panel is we bring up all the, the limitations but possibilities as well of moving the needle. If you want just a quick, short commentary on your...
Yeah, I got to fight back a little bit. So I love your comment, but I think it has to be, we don't think about surgery before endoscopic anti-reflux, we think about them together. And I think that's critical. It is a team approach, and there are appropriate scenarios for everything, and for sure, we don't do a TIF in the setting of someone who's getting eradicated.
Does everyone feel better now?
Yeah, that's not the point.
Yeah.
We're looking about a post-ablative
exactly,
or
like reflux control.
100%.
Yes.
Yeah, I don't want to give the impression that
we just want to make sure
there's
we're all
absolutely
on the same
a role for a TIF in an anti-reflux scenario. In this
so save that thought. So I want to go to the cases. I actually have questions too, including the
Can we get Trip real quick?
There's a person. Real quick, please. Thanks.
Very quick. So amazing talks. What a great session. I love hearing PDT because my first job was working for Gene Overholt painting PDT balloons. But we've come such a long way. And I think, Shri, your message of close that door. I mean, I've got a lot of skin, or at least mucosa in this game, because I've got Barrett's, long segment Barrett's. My door was closed, it's now short segment. And I hope as you all go to your big GI meetings, you'll socialize that concept, but then we get nuanced, right? So the ARB Collaborative is giving you a great way to say what part of that door needs to be closed, and then apply the appropriate anti-reflux procedure to the portion of the door that really needs closed. So what an exciting time. I hope you superstar GIs will go out there and socialize that. So thank you very much.
Thank you. All right, so we'll save your questions, please, and we'll just do the case real quick. So this is a real patient of mine. I'd love your input from the audience in the panel. This is a 72-year-old healthy man referred for Barrett's management from the outside. Remarkably, has a family history of esophageal cancer, not just Barrett's, both father and brother. In EGD in 2022 by an outside physician, remarked Barrett's esophagus. There was no prog class reported. We have no idea about length and lesions, et cetera, but we know he has Barrett's. So basically, the panel audience response in the setting of his family history of esophageal cancer and the presence of non-dysplastic Barrett's. How would you manage his Barrett's right now? Would you perform EGD with all the high-res endoscopy, NBI, Seattle biopsy protocol every 3 years, according to the guidelines? Would you perform EGD more frequently, annually, with all the tools we have, MBI, Watts, confocal, Seattle biopsy protocol? Would you perform prophylactic endoscopic ablation with RFA, given that he has a family history, even though he's non-dysplastic? Would you obtain tissue cipher testing? It's some sort of prediction risk model that will be talked about. And the current biopsies where they're non-dysplastic, and then do the annual EGDs, or do more than what we normally would recommend, or none of the above. So please vote, the audience. I'll give you a few seconds here, and then I'll ask the panel essentially just real quick down the line, 1, 2, 3, 4, and we'll go through the case, you'll see how it evolves. So can we get the responses? Can you read that? It's all over the place as far as I can see. But clearly there's some mixed options. They're all kind of nuanced, right? What you would do next in this particular patient. There's no real guideline that fits him. We know that the guidelines say that someone with esophageal cancer family history is at risk. It's not really well defined. And we don't even know how to do things differently in these patients. Would you do anything different, Sachin, in terms of more frequent endoscopy, preventive ablation?
Yeah, I think if my first question is, does this patient really have truly non-dysplastic Barrett's, right? So you've just got an endoscopy report that says history of non-dysplastic Barrett's family history, my first step would be to repeat this endoscopy and confirm that there's no prevalent dysplasia or cancer. That's step number one. And then I think this patient is someone that you need to bring in your clinic to discuss the option of ablation, given the fact that this patient has such a strong family history of esophageal cancer, and have that discussion based on all the data that you've generated from that index endoscopy.
Yeah, well, Sri, he's very concerned that he's going to die of esophageal cancer. What would you do in this case?
Yeah, I think it's. I mean, you could have made us just say pick a number, but I think that it's a high quality exam followed by a discussion of either risk stratification, clinical/tissue cipher. I think is an excellent option. I do that for this type of patient. I don't necessarily anymore go directly to ablation. Just with a family history, I will use tissue cipher to help me risk stratify a little bit better, along with some of the clinical tools that we have.
Okay, well, in the panel, who's using tissue cipher? Anybody? Just 3? Oh, not bad. How about in the audience? Anyone using tissue cipher? Oh, I'm amazed. Okay. All right. So, interestingly, this patient, we actually were able to do a high-quality exam. And we did do the usual high-quality exam and biopsies. And the biopsies from the one we did showed no dysplasia by pathology. We did do tissue cipher testing, and not surprisingly, actually, his risk was quite high. So if you look at, if you don't know about tissue cipher, it actually is a sort of AI molecular marker panel that uses 9 biomarkers, and it gives you a risk prediction based on the biomarkers plus anatomical changes in the gland stem cells from fixed tissue biopsies. And his risk was pretty high, 19%, and this predicts your risk within 5 years, and this has been validated in numerous studies, at least 5 or 6 trials out there. So this is where we have him now, and he has clearly a high risk. So any change, Jason, on what you're going to do next?
No, I think, you know, I would be kind of, if the patient was interested, you know, even, you know, at the index endoscopy, thinking about, you know, treatment for him, and this sort of, you know, I think pushes me more towards, you know, treating him.
Treating. Esophagectomy?
No, not there yet. We're aggressive, but not that aggressive. Yeah.
How about he has no GERD symptoms? We just do a wrap. I mean, he has a small hernia. Like, and at this point, you know, change his risk for progression. He has non-dysplastic Barrett's, but his risk is high by tissue cipher.
Yeah, it's a tough call. If they're not real symptomatic,
yeah,
you know.
Not offer him an anti-reflux procedure.
It's hard to go down that road if they're not real symptomatic.
Okay, so basically, he showed up a year later. He has high-grade dysplasia. Not surprising, right? And so it actually did kind of work that we were able to predict. So now we're in the setting of now he has high-grade dysplasia, and he clearly has a family history. What are we going to do now to eradicate the high-grade dysplasia in that setting? EMR, multifocal, ESD, complete, ablation. There was no lesions detected on the previous high-quality exams. Esophagectomy again, Tom. It's still an option now that he has high-grade dysplasia.
We're not insane.
None of the above. Please vote, audience. Phil, I'll take your question in a second. I can't read. Is that the new panel?
Very small.
RFA or cryo.
No one's
So
voting.
ablation
Consensus.
is the main vote that I'm getting. Sorry, I can't see because of my, there you go. Yeah, so a lot of people are voting, I guess, ablation given the absence of lesions, I guess, detected by high-quality exam. Anyone disagree with that in the audience? Sri, how about complete ESD? Or
no,
ESD in parts?
No ESD.
No ESD. All right, very good.
We can take that offline.
All right, next question. Next slide. So here's what the outside person, I did not see him for this, but the outside gastroenterologist, actually this is the pictures from that exam. There's actually some subtle neoplasia that you can see already. I can't point from here, but so at this same session, band EMR was performed on what was perceived to be the lesional Barrett's with high-grade dysplasia. These are the lesions resected. And actually at the same session, a little bit not typical, RFA focal was performed at the same session on the remaining Barrett's that was visible. Okay, so not typical, but you know, if you can do it safely as long as you know what you're doing. So, so here's where we are. We got the high grade out. There was no cancer in the specimens. What would you do next after eradication therapy? EGD with random biopsies every 3 years, EGD with protocol biopsies every year. What Sachin recommended, except skipping the 9-month, and none of the above. So audience, were you listening to Sachin? This is the one where you vote, hopefully the right answer.
None of the
All right, so very close surveillance is probably what we would do. Next slide.
Maybe can I just make one
sure,
point that you made with regards to the high-grade dysplasia diagnosis? Most of the times you're going to find a visible lesion to resect. I think that's the point that I think we all need to remember. When you have a diagnosis of high-grade dysplasia, and of course intramucosal cancer, you've got to find a lesion to resect. You need to ask yourself 10 times before you take that scope out and you put an ablation catheter down for ablation, is there a visible lesion to resect? And I think you made that point really well with that case.
Yeah, actually, our European colleagues in this case, it's not a very, very long segment, would have resected his entire barretts. I mean, it's not uncommon for Europeans to really be more, I guess, have a different view on it, that ablation doesn't remove tissue, and he definitely has the propensity to develop more neoplasia in the setting of post-ablation. Right. Phil, you had a question?
I don't want to preempt Stuart, but the biggest issue with this case to me is the following. Supposedly a high-quality exam was performed, yet the patient developed high-grade dysplasia within a year of that exam. You presented this case in part because of some interesting parts of the family history, but I don't think that's relevant to the case. Patients should have an endoscopy 1 year after the index endoscopy, regardless. And that's a place where, honestly, because there are guideline writers here, that has failed us, because this was a high-quality exam. Either somebody didn't do it well, no offense to you and your group, or it doesn't matter. We need to look at them again, and we need to look at them again quickly in this arena.
Yeah, no, good point. Actually, in my practice, I do repeat endoscopy, high-quality exam on all my referrals, and I've tracked this through the years. 50% of my patients referred have a different diagnosis from when they came, mostly upgraded by repeating it. And I don't know, it's hard when people come from far away that referred for something and you have to do, kind of what they were scheduled for. But it really is imperative for us to detect neoplasia that wasn't really detected outside. So anyway, the next follow-up endoscopies were performed. 3 months later, was actually possibly a Caesar M1 biopsy that was treated with halo frequency focal ablation. Follow-up EGDs for 3 years now showed complete eradication of metaplasia, and the patient actually developed atrial fibrillation, was put on anticoagulation. But eventually at year 3, there's really kind of no visible barretts initially, and the biopsy showed dysplasia, intestinal metaplasia without dysplasia at the EG junction, right? No surprise. We know from the data that 87% or so of the, if it's a true recurrence, recurs in the distal 2-3 centimeters of the esophagus or at the cardia, mostly in the cardia. And this is clearly in some books, I don't know, again, Nick Shaheen is one of the people who say if it's non-dysplastic at the cardia, it's not Barrett's, but if it's dysplastic, it's a recurrence. What's your comment on that?
Yeah, I mean, I think that's a paradigm that we're using at the present time. We don't care about IM in the gastric cardia or when you've taken biopsies just below the squamocolumnar junction, but we care about the dysplasia. And I think we have data from the Dutch group that have followed all these patients where they've found really no progression in patients that have IM detected at the cardia. So in fact, now they don't even take biopsies from the gastric cardia when they're taking biopsies for patients undergoing surveillance exams.
Yeah, I know, I respect that view, but I still feel, I don't know if the surgeons think that this is, sometimes it's one disease, right? It's basically, not only is there potentially some hereditary familial component we don't understand, but there certainly is some evidence that, cancer's going to rise from the cardia, right? And so I think to disregard, even if it's non-dysplastic at the time, this presence of intestinal metaplasia not in the esophagus, and someone like this in particular, again, nuanced, is something that can be debated, and this is not going to happen in this session, unfortunately, given the sign of almost wrapping up. But here's what happened. I did treat him with Halo 90 across the distal esophagus and the cardia, and this is pretty routine for a lot of practices. And then finally, 3 months later, as the usual protocol after, no visible barretts on the initial inspection. We always put the cap on, and this is what we teach our fellows and what we tell everybody, high quality exam. And I don't know about you guys, but I pay attention to little ditzels of columnar metaplasia in the esophagus. Sometimes people disregard this. And what I do is, in my practice, if I see this and it's clearly not a definable lesion, some people would either resect this or biopsy it and come back. But what I did in this case is we mapped, and so in this case it was clearly suspicious for kind of tip of the iceberg that it is a true recurrence. I've been being disease-free for those many years. So, but at the time I decided, I can't remember if it was Xarelto, that maybe not EMR this, maybe. But so I did do a biopsy and basically confirmed that this is high-grade dysplasia in a small island. So what would you do now that he's been crimmed and it's basically clearly a recurrence that's dysplastic? Would you do the same session, and then, this is not what I did, but perform EMR even with anticoagulation? Would you just biopsy and treat with APC? This is something most of us do sometimes, it's pretty innocuous. Just biopsy and come back later, or none of the above? This is, I think, the last question almost, so we can just wrap up. Please vote, and then I'd like to hear what the panel says about this step. Do we have any responses? So biopsy and come back. All right, so that's very reasonable, of course. So next slide, this is the last slide, I think, coming up. This biopsy again showed high-grade dysplasia. What would you do next? Is it time now for esophagectomy, Tom?
No, you can still retreat endoscopically.
Okay, all right. So EMR, ESD, cryo, esophagectomy, none of the above. Last is the last question. So please vote, and we're going to give you the final slide. And I really like guidance because this is still an active patient. And it's interesting that we have all these recurring discussions with the patient, given that he had 2 people die in his family, you know, brother and father. And so it's sort of nuanced based on the family history as well. So you can see there's a bit of variety in terms of what people would do. Any input from anybody in the panel?
You have to take the total context of this patient's disease. So his biology is not the same. We tend to treat these patients the same. We have robust guidelines, but people don't fall into boxes. And especially when we're dealing with oncology. So I heard the question about if you're putting TIF fasteners through barretts, it's cancer. It's not all cancer. I think what you have to understand is this patient has a different biology than most patients with barretts, which will be non-dysplastic or maybe borderline low-grade dysplasia, which such an inservant are studying. This patient had high-grade dysplasia. And I trained with Nick. I would argue that Nick would biopsy the cardia in this patient or the GE junction like you did and treat it because even though that's not dysplastic, at some point this patient's disease state has become high-grade dysplasia, which is carcinoma in situ. And I think for when you get a recurrence like this, you have to resect it. I mean, I do ESD. I wouldn't ESD such a small area. I would do EMR, and there's good data from studies that you could upstage this patient by doing EMR and find even more disease in that little tiny area left. So I think, number one, I would applaud you for going after that patient when they had non-dysplastic disease and continuing to treat this patient because obviously they recurred and progressed. And number two, I think some endoscopic resection here might even upstage it further, and you have to be aggressive. We can't treat all these patients the same. The reality is we'll have more and more biomarkers that will stratify the biology of this disease state. So some of these patients are going to be biologically different than others.
Sure, you want something? Or?
Yeah, no, I think the key piece here is that in this particular setting is that you have tissue. Those islands are notoriously, like you said, the top of the iceberg, and that's where you resected. So if you felt concerned about Xarelto and not taking an EMR, then at least a biopsy followed by therapy, just so you understood what was actually going on there. But the resection, I think, is the ultimate answer here.
Yeah, there's a question. I think this is the last. I know we're getting. Sorry, Mike's giving us the.
We're getting the cane.
We'll take one last question.
It's Plen Sat from London. Great session, thank you. Just a couple of points on refractory barretts. We've shown that with balloon-based cryoablation, we can get eradication for refractory cases in about 72% of patients. So that was published in Endoscopy in 2018. But for me, the bigger picture is if you see someone with refractory barretts, you've got rid of the acid insult, but they're still not having surface regression. For me, that's a red flag. These patients we know have a higher risk of developing visible lesions, they have a higher risk of developing pop-up lesions, and if you really aren't winning with these patients, we often advocate keeping a very close eye on them. So actually not rushing to get your ablation catheter out, whichever one you choose, but watching them like a hawk and actually waiting for them, if they do develop residual neoplasia, that you can actually treat endoluminally. So for me, it's just a bit of a red flag not to just treat, and sometimes slow down and watch. I'd be grateful to hear what you think about that.
Yeah, so we're supposed to close. Can I have 30 seconds? Of course. Thank you so much. We started late and we had glitches. So I wanted just to make a last comment on cryo and cancer. Because, you know, when I got into the business of cryo years ago, I had to understand how it works. And what was interesting to me is in other solid organs, you know, kidney, liver, prostate, it's actually neoadjuvant in a setting that, in the sense that it induces a systemic immune response. And the systemic immune response is not seen with heat energy. It's really just with cryo for some reason. And I saw one other DDW abstract was very prompt. It was post-ESD patients with esophageal cancer who were treated in a neoadjuvant fashion. And basically they had complete remission for, I think it was a 3-year, it was very exciting, using cryo in a neoadjuvant role. So I think it's a very promising way to move the needle. I think, Shri, the way we're saying we should really think out of the box and kind of collaborate and do things together.
Yeah, we actually looked at our, you know, from our original trial, folks that got like, you know, got cryo and compared them to folks who just got chemoradiation, and there was, you know, an increase in cytotoxic T cells, tumor infiltrating lymphocytes. We didn't have enough tissue for PD-L1. We have tissue from our second study too that we're hoping to analyze, so hopefully it'll shed some.
You need to do a big trial. This is amazing. This is really going to be exciting.
So I'm going to just say that I've been to a lot of meetings where people vote with their feet when we run over and you start to see it trickle out. I don't know that we more than 5 people have left. I want to thank everybody for a phenomenal session, that you voted with your feet, that we need to pay more attention to this in years to come. Thank you. We're going to go to break. We're going to begin